Good morning. In the name of Prevention and thinking of your health, the University of Los Angeles and the Association of Medics Information, Dr. Reyes as well, we give you the warmest welcome into the second day of the second Congress and third Congress of the prevention and well-being of adolescent and infant mental health. Once again, welcome to our speakers and to our participants that are visiting us from far and wide to listen in on this symposium and congress on the prevention and promotion of mental health within our younger population. We give our gratitude and our thanks to the organizers of this event, and we give our greetings to nationals and international participants. If you let go of your fears, you will be open to new and challenging experiences. Now, I am very honored to present Dr. Paulina, who works as a medic professional and as a researcher in the Faculty of Psychology in the University Autonomous of Mexico. And within her experience, she is distinguished with her collaboration with the Pan American Social Health and Organization of World Health. She has dedicated her career into the development of practices that enrich the treatments and interventions for mental health, especially in the prevention of suicide ideation within our younger population. And I give space for Dr. Paulina to begin. Good morning to everyone. Thank you, Axel, for that warm welcome. Thank you, everyone that is with us today. We're going to start sharing the screen for the presentation in order to begin. Great, there we go. So we'll be taking a look at the chat if anything technical comes up. Well, first off, it's a great honor to be here speaking about this topic, about how we can identify some elements and characteristics that can help us to know whether or not a person, especially an infant or an adolescent, has some sort of self-harming behaviors or ideation, suicide ideation that needs a specific form of intervention. And this is what today's talk will be about. I'm gonna try to go slow so the translator, that's me, will be easier and more efficient and closer to the reality. So basically, we're going to be talking about the identification and the interventions that are recommended to prevent the suicide ideation. And the purpose of this conference is to know more about the elements and where we can identify the risk of suicide and risky or self-harming behaviors. And once we realize and know about these risks and identify them, and we'll get closer to our purpose, we can focus on the younger population and adjust our techniques into that. So, and within our objectives, we have to contextualize into the population. Like I mentioned, we have to define what is suicidal behavior, identify the factors that are associated with suicide, and present a risk management that is based on collaboration. We're going to be talking about some of the elements, general elements of a model of intervention in order to elaborate a security plan in response to a crisis and identify elements that are essential in the intervention, whether they be psychosocial, especially with the guardians or the web of support that a patient may have. We'll be seeing more specifically the factors of the risk factors that we can identify and how we can react to these respectively. This particularly comes from the plan of intervention in regards to a crisis that I mentioned. Well, teenagers, for example, that are most likely to present risk, we do this in function with the guardians and the family members, which closely relate to this child, infant, and teenager at risk. Now, in regards to the specific population of infancy, of adolescence, and young adulthood, there's a lot of phases in the development with many biological changes. And it could be a physical change, hormonal change, neurological change, emotional change, and social. Really, when we look at it at a macro perspective, we just see biological changes. But here we have, or I mentioned, the more specific changes in a more micro level, the physical, hormonal, neurological, and emotional changes. And these phases really are fast changing, ever evolving. Elements in their day-to-day lives. When these children or teens are not able to cope with these changes is when we have to look out for the risk of development, risky behaviors, and self-harming behaviors. Now, these changes that are established from infancy kind of halt when we begin going into the adolescent years, but they're replaced by others. They're not just thrown away per se. And the same thing happens when a teenager is entering young adulthood. There are different changes that are occurring, but they're not the same as adolescence or infancy. So it's really a process of growth that is very important when we talk about the transition from infancy to adolescence to young adulthood. Now, this is fundamental to contextualize because from this, we can jump off into identify the risk factors because at every stage of development, there are different risk factors. So we should always keep in mind and contextualize which population we are dealing with and how behaviors can change with this in mind. Now, it's very important to know that human development is very important in regards to physical changes, physiological changes, and our mental health may be determined by the state of these biopsychosocial factors as well. It is more than established in literature how the emotional, the physical, the hormonal changes affect our biopsychosocial environment. And many of the problematics that we may encounter arise from this topic. So definitely, again, I should emphasize that these changes are not a defining factor or per se a determining factor that it will confirm risky behavior, but it is a factor that can heavily influence the development of self-harming or suicide ideation problems. By the difference in responses to these changes, we can identify the infants and the adolescents, especially the adolescents and the teenagers, where we can identify a very vulnerable stage because of the neuroplasticity and the biopsychosocial changes that they are facing and how vulnerable they are to social pressures, for example. On top of that, they can be in very vulnerable environments, whether it be with their family, with their school, with their relatives, with their friends. So there are many risk factors that can make an adolescent vulnerable to develop risky behaviors. Now, talking about those that need to use their adaptive skills, this plasticity, neuroplasticity that is naturally had during the stages of development, gives the infant and the adolescent the capability to adapt to their environment. And if there is a deficit or there's an incapability to this, we can say that there's a stressor that is a stressor stimulant, and they're not considered a factor into the development of this child and adolescent. So the child and the adolescent is at risk due to this stressor. So who are we going to be facing a more difficult challenge? Well, this is, again, population that we're being focused on this Congress and Symposium, which are kids, adolescents, and young adults. And really, there is a high impact level, not only in the individual, but in their immediate environment. So this doesn't necessarily mean only their parents, but also their extended family. So we think about the nuclear family, now we have to think about the external family, which also have an impact on how they look or perceive the child as part of the environment, where it may be detrimental to the development of its child or adolescent or young adult due to stereotypes, due to prejudices, due to beliefs that they may be imposing on the child. And because of these beliefs and stereotypes and prejudices, the feelings of the younger population of the child in question may be invalidated, and this again puts the child at risk of developing risky behavior and suicide ideation. Now, there are some myths about this population and the risky behavior. And it's very important that we recognize these myths and, of course, bust them, as one would say. For starters, some of the things that we might hear from parents or extended relatives is, for example, oh, these kids don't listen, nothing matters to them, which is, of course, untrue. Children and adolescents and young adults are very perceptive, and these beliefs of they're not listening, they don't care about anything, may give an impression of indifference and apathy from the caretakers and guardians towards the child, and in turn may have a very detrimental effect to the mental health of the child, which really, like I mentioned, are highly perceptive and maybe don't know how to express themselves. We may realize later on in our years that they really did understand more than we gave them credit for. So this is a myth that we definitely have to keep in mind when we come across parents that give us this kind of expressions. Another myth that is prevalent in our society, especially in guardians and parents, they're like, oh, kids, nothing's going to happen to them. They're young. It may be perceived as kids are like plastic. They can adjust to anything without any issue. And of course, it is true that children and young adults and teenagers have a higher neuroplasticity capacity. However, it is important to contemplate and contextualize the stressor that they are under and the impact that the stressor is having on the mental well-being of this young population. When we realize the prejudices and the myths that are present within the child's environment, we can properly address and give a better model of intervention in treating these risky behaviors and suicide ideation. Now, there are certain behaviors that are going to ring alarm bells in our head, like asocial behavior, isolation, incapacity to communicate precisely, when they don't or aren't inclined to share their preferences, when they're partaking in risky sexual behavior, or when they are self-harming. These are only a few of many risky behaviors, but these are definitely the ones that we should be looking out for most, as they are the most common. Another one that I should mention is any kind of unhealthy food relationships that we see. It may be ranging from binge eating to anorexic behaviors or to body dysmorphia. But of course, it really depends on the age group that we're talking about. And we have to be very careful when observing these behaviors, because as well, another risky behavior that we should mention is the consumption of substance abuse, of substances that are potentially addictive. And we may also consider where they are sourcing these from, if they have seen this behavior from a family member that have made them prone to go seek those substances, and that have made them vulnerable to develop the addiction. And these risky behaviors, of course, can lead to suicidal ideation. And what do we call suicidal behaviors? Well, it's this in this graph we can see a sort of scale or a spectrum on how we evaluate suicidal behavior. And we can see at the far left where we begin with self-harm, where it establishes that behavior that is associated with hurting oneself without the intention of achieving death. It really has more of a function for decompressing or alleviating a deep and profoundly set emotion. And right beside it, we can see suicide ideation, where we have and we see recurring thoughts associated with the death and the intention to die in order to achieve death. So this is what we call suicide ideation. Now in the center of the scale, we can see suicidal plan. Now this is where we have a thought associated to the intent or the intention of terminating life. And we see that there's a clear plan with a series of steps that are organized in order to execute the plan and, well, achieve death. Now, on the second to last, we have the intent of suicide, sorry. So this is when we see a behavior that's associated with a self-harm that has the intention of death. So we can see the difference between self-harm and suicide intent. So the difference one being they have no intentions of dying, and with the intent of suicide or suicide attempt, there is the intention of dying. And on the very far right, we have suicide, where there's the death caused by self-harm behavior that's, of course, damaging to, with and has the intention of dying as a result of suicidal behavior. So if we go back again to the top and see the scale, we can see that on the right, we have the purpose or the intention of death. And on the far right, we have death. So it really is a scale, and it can escalate depending on what they are living through, how they are being supported or non-supported, so the lack thereof of support. These types of behaviors can be presented by young adults, so adolescents and young adults, where they are most vulnerable to biopsychosocial pressures, and where they are facing how to, or learning how to develop their expression, how to communicate their feelings. And when they are unsuccessful in finding a way to do so, they may develop these risky behaviors across the spectrum. But of course, it's important to, I guess, get down to the grain to determine and ask whether or not they have the intention to die. Mostly we'll see conducts where they are focusing on alleviating their emotional pain, whether it be guilt, shame, grief, sadness, and they have no other outlet or no other outlet that they benefit from. So when we talk about suicide ideation, we can see thoughts that may relate to or sound like, I have no purpose in life, I can't see myself living in the next year, I don't think I am worth anything, I am worthless, and I want to die. So this really is more of a suicide ideation. And of course, when we have the suicide ideation, we can see and somewhat through a plan, but it's really important to distinguish that just because there is suicide ideation, there may not be a plan. So we have to be careful in identifying the differences between these terms and get down to the grain, where we have to ask or have to observe whether or not they have a plan, if their plan has steps, if it's an intention that they are working towards currently or in the future or have been, because this places us in different points of development. And of course, in reality, we have different contexts that can dictate patients' development due to the environmental factors. So because of the context of high violence or context where there's a lot of excess of everything, it may lead or may create a higher trend of these behaviors. So again, we have to always take into account the context where the kids or the children and the adolescents are understanding it and how they are perceiving suicide ideation from a more social perspective on their environment per se. So again, I just want to highlight the difference between self-harm, where there is no intent causing death, and where there is a suicide attempt, where there is self-harm with the intention of causing death. So this is when we have to really get down to the grain in order to determine whether a behavior is just health harm or if it really was a suicide attempt. And of course, it is very important that we don't minimize the risk or minimize the behavior. Any type of self-harm or any type of suicidal behavior is dangerous and should be taken with the seriousness that it deserves. We should never minimize any of the any act that revolves around self-harm or any behavior that puts at risk the physical integrity of a person, or just as well the emotional health, the emotional integrity of a person. And again, we mentioned the importance of the context that a child and an adolescent and a young adult is within that may dictate the risk of them developing self-harm. But it also is important to mention that certain environments that are kind of violent or unstable that just increase the risk. It's not necessarily a determining factor. It's just a risk factor that may develop into suicidal behaviors in a young person. Now, here I'm going to be talking about the focus of the principles of this model about suicidal behavior with a foundation on learning. So this is basically a strategy of emotional regulation and problem solving that is oriented towards an escape or an intense instability, emotional instability, and a method to change situations in certain life events. And now this conduct of behavioral therapy is oriented into acquiring and developing the skills that not only help us prevent suicides or suicidal behaviors, but it also reduces emotional instability and the emotional suffering that a young adult may be facing and developing due to the stressing factors of their environment. So the advantages of this is that it is based on clinical evidence and clinical investigation. So it's medicine-based, evidence-based treatments and models that are and have been backed up by a series of research papers. This same model can help prevent developments of addictions to substances or any personality issues like per se the bipolar disorder or asocial behaviors. And in general, it's a good treatment for teenagers and young adults to experience in order to learn how to manage their negative emotions and not get frustrated as easily and develop into more serious issues that may lead them to develop self-harming behaviors or suicidal behaviors. Now, what do I need to know to identify the risk of suicide? Well, first we have to know clearly what are the risk factors, such as a few factors that can precipitate or cause a suicidal crisis or emotional crisis that may result in a person attempting suicide. And of course, knowing the adequate intervention that is indicated or recommended when these cases do come up. So when we talk about risk factors that are acute, we think about immediate or proximal. That is to say, personal or environmental. This can be physical factors. This can be, like, for example, someone that has consummated a addictive substance and has as a consequence developed an euphoric state and have developed a more vulnerable position for the person, and cause as a result a emotional crisis. So this was just an example of an acute risk factor, right? It's when a young adult, adolescent, an infant is in a very emotional, vulnerable position. There are plenty of other examples, but just again, there are acute risk factors, physical, just as they are emotional, just as they are psychosocial. And just to name another few is living with hopelessness, living with desperation. And well, again, it's very important to consider the context that this child, an adult, teenager is living with that may precipitate these feelings of hopelessness and stagnation and really the losing of the will to live. Now, what about the chronic risks? So these are the other end of the spectrum from acute risk. So this is, for example, the different behaviors that a person has acquired during their entire lifetime. And this is really more associated with the acute risk factors because it's where we develop habits. Like, per se, alcoholism or substance abuse and other problematics that are developed or can be developed in adolescence. The chronic risks are very important to consider when we are interrogating or looking into the suicidal conducts in the adults that we are treating or talking to. And when we are faced with these cases, it's important to not necessarily evade, but not relive the past in order to prevent reliving of trauma and precipitate suicidal conducts. Now, just as there are risk factors, there are also protective factors that can promote a better well-being, emotional well-being in infants, adolescents, and young adults. And from here, it is very important for us to identify these protecting factors in order to further stimulate them and promote them within not just the infant, young adults, teenagers that we're dealing with, but also promote them among the people that are in their environment, such as their parents, guardians, their family members, friends, to further enrich the life of this emotionally unstable patient. So sometimes we will be facing parents or guardians that have their own issues, and we won't always be able to direct and orient parents into promoting these protecting factors, but we should always try and put forth our best footing. Now, sometimes when we observe these risky behaviors, we think, well, what can I do about this? Now, me as a doctor in psychology, we have to think about always working in teams. We always collaborate and think about the interventions that are more, I guess, that are more efficient in preventing suicidal behavior. And more than anything, we're always questioning ourselves into how we can improve the interventions to further fertilize the emotional well-being of our population, young population, and prevent suicidal behaviors. We have decades of work and research behind this, and it's very important to keep working in teams because it's a community issue. It's not an individual issue that can be faced by one doctor or one psychologist or one psychiatrist. It's really a community effort. It includes family, it includes nuclear, just as extended family, it includes schools, it includes friends, and that's how we can fertilize and prevent suicidal behaviors and strengthen emotional supports. There is a model called Dynamic of Orders of Suicide Risks called MODORIS, and it has as a purpose to structure, organize, and coordinate the attention to people that are at risk of suicide based on community interventions. So the first step is to identify the factors of risk and the factors of protection. Then we have to make a evaluation of the risk of suicide, which this does have to be made by a medical professional or healthcare professional. And the third step is to make an intervention to the suicide behavior and to know that it really is a responsibility for us to prevent more suicidal behaviors. And well, I come back and say that it's important to recognize our responsibilities. And of course, to this, it's always important to refer to professionals when we are, per se, out of their depth. This model is presented in a visual diagram of how it can be escalated to. So from the bottom up, we have the community environment, the environment where there is no need for specialty attention. The third level, where we have a patient that needs specialty attention. And then in the fourth level, we have a patient that needs hospitalization. So this is the implementation of the model at a national level within institutions of the University Autónoma of Mexico. Now, basing ourselves on this, it's very important that we know which actions can help prevent suicidal behaviors in general, like, for example, self-harm. And when we cannot prevent these behaviors because they are already set, we have to look into what we have to do in order to land some actions that are feasible for our patient. We have different universities that are collaborating and developing these interventions. One of them is the University of Aguascalientes. Now, in these three elements that we have developed, which is identification, evaluation, and intervention of the suicidal behavior, we can or have created a course that can teach us how to realize these three things. And really, we have here a diagram that has shown us if we are fulfilling certain roles. For example, if I am a first responder part of the community, we are a brigadist. If I am a healthcare professional, not specialized, like social workers, nurses, medics, academic psychologists, workers, or others, That's the second level. The third level is when it's a healthcare worker that is specialized, whether that be a specialized nurse, a psychiatric social worker, a clinical psychologist, and a psychiatric doctor. That's the third level. And each level would be even more advanced specialists. So these four levels of people and role can help us evaluate the risk. And what are now we have to consider what are the tools we have to evaluate the risk. There are some tools like scales and questionnaires and also interviews that can help us identify these risks, but really it's a mix of these two. The interviews are with people or young adults with high risk of suicide, and it is really important to establish a relationship between the specialist and the young adult at risk in order to form a relationship and establish a safe environment to establish proper communication and, of course, confidence in the relationship and the future of the relationship. Now, it's very important to treat this vulnerable person with respect and with courtship. Now, when the evaluation is taking place, there should be a series of questions to find out what are their reasons for living, for dying, their factors of risk, whether they be chronic or whether they be acute, and the factors of protection in order to promote these, like a web of support that we can reach out to in order to enrich the vulnerable person. We have to be very careful with how we are wording the subject and be very precise with our language in order to reach the answers that we are looking for without making the person strange or feel uncomfortable and entitled to medical attention. Now, how do we approach this intervention? Well, there first has to be a management of the suicidal behavior, and this is something that we can all do. There is plenty of guides with principles and steps to follow in order to minimize the acute risks or suicidal behaviors or immediate problems. And this can be achieved in any level of attention in the public health sector and in any public setting. And of course, within our communities, whether that be schools, places of work, sports clubs, religious groups, and, well, just the public setting. And the second is the treatment of the suicidal behavior. And this is, of course, only achieved through the personal of the healthcare workers that are specialized. And these are people who work with when problems persist and when we have to reduce the acute risks in order to further stabilize the patient. And the specialized approach includes psychologists and medical psychiatrists, and with psychotherapy or with cognitive therapies or behavioral therapies. And of course, this is performed in the healthcare center and in public institutes as well as private institutes. Again, in this second treatment, it does have to be executed by medical and healthcare professionals. It is a more specialized approach. It is a more delicate, and it requires a more developed training personnel in order to meet the needs of a vulnerable person that specifically needs. Of course, psychologists, clinical psychologists, and psychiatrists are equipped for this type of intervention, but it really is important that when thinking about this intervention, this treatment of the behavioral suicidal behaviors, we seek mostly from medical professionals or clinical psychologists that have been trained in this particular field. We can't just go to any healthcare worker and expect this high level and precise form of treating suicidal behaviors. Now, these are some of the elements that can help us create a safer environment. Like, per se, is try to avoid religious beliefs or religious prejudices or personal prejudices that we may impose upon the vulnerable population. And in a more global setting, we have to think about the psychological first aid when thinking about risks, suicidal risk. And common questions that we can ask are, how are you? How are you feeling? And afterwards, listen with attention and be very attentive to who we are listening to. We also have to listen very carefully to see we are dealing with suicidal thoughts, but of course we have to avoid imposing our judgment or criticism in order to establish a better relationship between the responder and the listener. And of course, if we do show some sort of critic or judgment, the relationship may be detrimental, but more than that, it may deteriorate or further deteriorate the self-esteem or the emotional well-being of the person that is trusting us with their feelings. And of course, we can see in many cases people that are just saying like, oh, you should think of your family, oh, you should think of your role in society, and those kinds of responses are not helpful. What is helpful is listening and being compassionate during this time and responding saying, I'm very sorry for what you're feeling and what you're going through, but you can count on me for the support and for someone to listen to you when you need it. This kind of support is a more positive way of intervening and really just supporting the person that needs that emotional support. As a professional, it is always important to identify if there are people in the patient's environment that are these active listeners that they can seek further support from and really strengthen that relationship, because carrying that kind of pain and that kind of guilt and shame can overwhelm a person. So really, as professionals, identifying this fruitful and important relationships is key. Now, this is a 7-step plan to secure the collaboration. And now, of course, it really depends who we are and what structure we are participating, how we follow the steps. But to begin, it really boils down to reducing the access to lethal objects or substances. The second is to generate strategies of solutions that are not suicidal, so enabling young adults, teenagers, and infants to resolve their emotions not through self-harm. The third is to activate and look for this web of support that I was mentioning earlier. The fourth is to generate a phase of affronting the issue and looking for reasons to leave. The fifth is to identify forms of resolving problems in order to carry out a plan to continue on living and in a healthy way. The sixth is generating a compromise. And the seventh is to always give follow-up to these patients that are at risk. So when we are following up the seventh step, it's important to evaluate the level of risk that the person is in, to really see if they have been seeking support or if they haven't, and explore if they have any doubts about the strategies that they have been taught. And from there, we can identify if there's ideation, if there's planning, if there's self-harm continuing. We can see if there is an opportunity to promote more healthy behaviors and encourage them to seek those alternatives that we provided earlier. And of course, we have to always consider if it's a necessary step to intervene once more. Now, when talking about the guardians and the people that are around the immediate environment of the vulnerable patient, it's very important to orient them or try to orient them into what their patient and their child is going through, because, of course, just as their child is going through emotional stress, the parents are going through and all their emotional difficulty and maybe feeling high levels of stress, of guilt, of inadequacy. So in this regard, we have to validate the emotions of those family members when they're talking about the risks of suicide that they're facing, and we have to orient them on how to communicate effectively and without criticism or hostility. So basically, we have to cycle about suicide. We have to clarify the myths. We have to validate the emotion of the child, the adolescent, and the adult. And we have to promote the restriction of mediums from understanding what is going on in the mind of their child, of their young adult, and their teenager. And of course, the last step is to reinforce the commitment that the guardians and family members have in order to generate strategies of collaborative solutions and not really impose. So really, it is a collaborative approach. And in terms of elements of reflection, the majority of suicides are preventative if the person decides to start treatment that permits them to amplify their repertoire of conducts that promote healthier developments of emotional stressors. And we have to talk more about suicide because just talking about it doesn't really promote or prevent it. We really have to consider which approach can consider the vulnerability of each individuals and how to adapt to those. Of course, behavioral suicide is a sign of emotional suffering and it is very individual. If suicidal thoughts or self-harm is present, it's always immediately need to seek help. It's a red flag that we should always seek help. And we have to reduce the risk factors or the elements that may enable a person to self-harm. Now, as a conclusion, the work with people with suicide tendencies or behaviors is complex. It requires a really profound and academic training, professional and clinical experience that is supervised. The professionals in mental health are always in high risk of burnout, so we have to keep that in mind. We also have to promote the interventions that are based on clinical evidence and always work towards a collaborative environment as a professional, not only to prevent death, but really promote a better sense of health and well-being. So here are some of the materials that I have given you to consult on the Faculty of Psychology in the university. And there's also a more clinically guided approach that is and may be beneficial to all of you that are studying in the health sciences. Thank you so much for your participation and for your interest in learning more about the mental health in our younger population. Here are other resources where you can reach out for more information and attention to vulnerable population. Thank you so much. It's very sad what we see in adolescents and kids where people or their guardians aren't really listening to their situation and their emotional distress. We can see a situation of abuse where parents or guardians are very dismissive of their experiences and simply say, oh, he's your uncle, he didn't mean it, or oh, that's not true, it didn't happen, simply an age or a power dynamic that is being implied. So the importance of our intervention is also guided towards the guardians and the family members in order to address this issue from the roots. And Dr. Paulina is saying here that it's equally important to validate the feelings of inadequacy, of guilt, of being afraid in order to learn how to better orient the parents in responding to these crises or these calls for help, and really stick to the plan of intervention that the health professional has recommended for that particular case. Which is why we recommend not only interviewing the patient, but also see what the family dynamic is like and see how the mental health is for that really comprehensive and collaborative approach to reducing suicidal behaviors. So what we can do when we can identify alerts or behaviors of alert, and there are many ways to do this, and one of them is trying to hide them, of course. It's one of the ways that I believe and firmly believe that we don't have to wait for these behaviors to develop. More than anything, we have to focus on preventing the development of these behaviors by educating, by communicating, by giving parents, guardians, family members tools in order to establish a better and more holistic and healthier environments in which to take care of their kids. So not only is verbal directions useful, but nonverbal language is even more important in approaching the observation part, importance of identifying alarms. It's very interesting what you're commenting on, Dr. Paulina. We're very thankful for your contributions in order to make proper interventions when thinking about suicidal behaviors and suicidal tendencies. So we are now handing off the online constants to Dr. Paulina.